Welcome back, and we'll get started. So my talk is patient satisfaction, what to do to look your best. All my disclosures are on the Academy website, and it's updated every 6 months. My other disclosure is that all my patients are 100% satisfied, and I think I already look my best, but anyway. With regards to patient satisfaction, it totally depends on whether we can meet the patient's expectations. And if you look at the literature, only 78% of their patients have their expectation met. And doctors and patients don't always agree on what is a good result. So if 78%, if we're all type A's, that's a C. That's not going to get you into med school. And we also see that the strongest predictors of discordance in patient certain satisfaction is, again, if we don't meet the patient's expectations. And what's interesting is if you question patients who have low satisfaction and then you question the surgeons, the surgeons are way more satisfied with the outcome than the patients are. And so patient and surgeon evaluation of outcomes are coming from different perspectives. So patient satisfaction, I submit to you, is nowhere near as high as what we've been reporting in our literature. And because of that, the payers and the government realized that a few years ago, and they started to closely monitor it, publicly report it, and now it's closely linked to our reimbursement and our compensation. And because of that, if you want to get Joint Commission certification or for advanced certification to be a total hip and total knee center, you have to have PROMs. You have to have some type of anonymous survey that objectively measures your care and how the patient feels their experiences. And so we've adapted in our institution the Who's Junior score. We get it on every patient pre-operatively, and to be compliant with Joint Commission for our advanced certification. It also has to be obtained post-operatively, and it's all part of our protocols now. But to look your best and satisfy your patients is really not rocket science. It's basic, it's basic. You gotta be affable, available, and you gotta be able to do it. And you gotta communicate. And the key thing, I think, is always respond to your staff, other physicians, or whoever calls you. I think it's really helpful to have dedicated teams. I have a dedicated team in my office, I have a dedicated team in the hospital, and I have a dedicated team in the OR. And I work with these people about 99% of the time. Same people every time. Pre-operatively, I think you have to do patient optimization, and we've heard about that. It's not that the BMI has to be 40 or less. It's the issue is that the patients have a BMI of 40 or greater obese have metabolic syndrome, and they're sick. And a lot of the things that they have that make them sick are confounding, and they sort of layer on each other. The good news is a lot of those things can be modifiable. A1C is one of them. We have a cutoff of 8. That's a soft cutoff. Some places pick 7.5. There's a lot in the literature now to talk about fucosamine. Alcohol abuse and chronic opioids, I tell everyone you cannot treat psychosocial problems with surgery. If patients are alcoholics or drug abusers, the answer is not just to go do their hip. You've got to treat these underlying problems. Patients with chronic pain have to have a pain contract. Some of them have pain management. And absolutely no smoking. If you smoke, you cannot have an elective total hip or total knee in our institution. There's plenty of data that now shows that smoking significantly increases the postoperative complications. And so we don't routinely get carnitine. We have this machine in our office. We can test them in real time, and we can tell them what they are, and we can show that to them. And the two things that'll get people to stop smoking is, one, if they hurt bad enough and they want a total joint, and two, if they're pregnant. After that, they may go back, but this is a hard stop for us. Medical clearance, you've heard different options. We do get medical clearance. We use the PCP, specific providers. We are looking into hiring our own nurse practitioner or having our own team to evaluate patients. Dentition, We do get some type of dentition evaluation labs. It's basic CBC, BMP, A1C, and we're now talking about whether we're going to check the fructosamines instead. We've stopped getting UAs. We don't get chest x-rays. We do get nutritional markers on everyone, and it's amazing to see how many patients are malnourished. We started people on vitamin D protocols. There's enough in the literature that shows that, certainly in the trauma literature, that a low vitamin D is associated with increased infections. And we did follow the Joe Lang Hospital for Special Surgery protocol to treat vitamin D deficiency. About a third of our patients, we were surprised, are vitamin D deficient, and so we started treating them. This changed this year. We changed it. We stopped testing it because of two reasons. One, it's expensive to draw it, and two, many of the insurance carriers don't cover it, and since 30% of our patients had it, we now treat everyone. They get vitamin D2, 50,000 units once a week for 8 weeks, and vitamin D3, 5,000 units once a day for 3 months. And we're now looking at also getting pre-operative DEXA scans on certain individuals over the age of 65. If they are malnourished, we send them to a nutritional consultation. If they're overweight, we discuss to them certain options. We start prehabilitation with physical therapy, not a prescription, but we do give them protocols. There's enough in the literature now talking about bariatric surgery with the sleeve options, but there's some literature coming out that whether they have it or not may not affect their postoperative outcomes. Imaging, we do get standardized x-rays. We get a low AP standing, cross-table lateral, sitting and standing on certain positions. All standing x-rays do have a radiographic marker, and it's imperative that everybody be templated. We do get these views. There's a lot of variation. We're trying to sort of figure our way how to interpret it. I think it's maybe less of an issue with the DA approach if we look at our complication rates, but certainly something we talk about. Education. Prior to COVID, we had in-person educational programs. We review expectations. We discuss prior to surgery with the patient and who's ever taking care of the patient. What's going to happen the day of surgery? Are they going to go home the same day, the next day, or are they going to be admitted? What are their postoperative plans? And again, we explain to them our expectations. We assess their abilities, and we determine what assistance they need and who in their family is going to be providing them, and we go over the timeline. Once we got hit with COVID, we went to virtual. We put all these classes online. Each patient gets an email with the link, whether it's a hip or a knee, and then they get a follow-up appointment with one of our educators that meets on the phone for about an hour with the patient and their coach with regards to what's going to happen and make sure everybody's on board. They do get a booklet that goes over all the protocols as well. In there, we have all the numbers that we want them to call, except to call the ER or the hospital. We tell them exactly what numbers to call if they have an issue. We go over the most commonly asked questions. We make certain that they have ways to get through to us, either through electronic medical records or emails, but it's important. Pre-operatively, with regards to pain management, we all use the same protocols. Every patient gets Toradol. It's determined how much they get based on their age and renal function. We continue it post-operatively for 4 doses. Everybody gets PO Tylenol. They start pre-operatively, continue post-operatively for 4 doses. Intra-operatively, everybody gets a spinal. If the anesthesiologist can't do a spinal, has to do general, they have to document it in the chart because that is part of the requirements for advanced certification as to why the patient could not get a spinal. Intra-articular injection, everybody. I'm not going to give you my cocktail. There are so many different cocktails. Pick one and use it. We do give them Decadron pre-operatively for postoperative nausea and vomiting. It does help with pain. We decrease the dosage for folks who are diabetic. Postoperatively, as I mentioned, we continue the Toradol, continue the Tylenol, and now we're starting getting into our PRNs. Everybody gets Tramadol or Ultram. We also do prescribe them some PO opioids, but again, PRN, cryotherapy for everybody, and we use Mobic because we don't have to fight over Celebrex with the insurance companies. We do give them an H2 blocker because of potential side effects from the nonsteroidals and aspirin we use for DVT prophylactics. Everybody gets probiotics for 1 week because of C. diff and constipation. If they're on narcotics, they get a stool softener. They discontinue when they're off the narcotics. With regards to urologists or Flomax, if the patient has a urologist, we have them see them, and we only prescribe Flomax if their urologist recommends it. We do have the ability to give them Zofran and scopolamine patches. I'd be careful if patients who are a little bit older to give them the scopolamine patches. Intraoperatively, consistent. We've got to remember the intraoperative antibiotics, 1 hour prior to incision, and it has to be weight-based. I do irrigate with betadine as well as some of the Hipoclen's dilute solutions. Close the wound in layers. I use a compressive dressing. Very rarely do I use an incisional wound vac. Expedient and expeditious treatment of any wound problem. And anyone, these don't get better with darkness and another dressing right away. If you've got drainage, you take them back ASAP to evacuate it. With regards to some of the attention people are getting on extended PO antibiotics when they get discharged with the so-called Meneghini protocol, it's not really clear to me what the indications are for that. But if you have a high-risk patient, then it's certainly worth entertaining. Intraoperative imaging, I think it's key. The anterior approach makes it a lot more user-friendly for it. You can assess component position, offset, center rotation, limb length. You can assess the fit and fill of your acetabulum and femoral component. And it gives you a mulligan. It gives you an opportunity to modify and adjust before you close the wound or even before you open the implants. And it allows you to see whether you've gotten your preoperative goals and avoids outliers. Tom Schmoller once said, an intraoperative x-ray, a surgeon will accept nothing less of perfection intraoperatively. On a recovery room x-ray, we will accept nothing short of disaster. So I'm a big fan of an intraoperative x-ray. Pre-operative managing, we have certain triggers that we would get them to be evaluated for a low hemoglobin. I can't remember the last time I've transfused anybody. Careful hemostasis intraoperatively, tranexamic acid for everybody. Everybody gets it intraoperatively IV, 1 gram on call, 1 gram at the end of the case. We've stopped giving it 6 hours later. If you get for any pushback, you can use it topical. There is possibly a role for oral. That incentive was financial. The finances come down. If you do use it oral, remember it is a pretty big pill. The key thing is to remember the half-life. IV is 2 hours. If you use it as a solution or irrigation, it's 3 hours, and PO is 12 hours. Post-operatively, we have a trigger of 7 to transfuse if they're symptomatic. There's enough in the literature in young people, you can go down to 6 before you do any transfusion. DVT prophylaxis, we use the AO stratification with regards to risk bleeding versus the risk of PE, and they're all listed here, who's at risk for bleeding and who's at risk for pulmonary embolus. People who we feel are at risk for having PEs or revisions, we'll put them on Coumadin or low molecular heparinoids, compressive stockings. Most of our patients who are low risk, we give them aspirin, 81 milligrams BID, and TED stockings. If they're high risk for bleeding, we simply go to TEDs and compressive devices. The most important piece of equipment that I have is my telephone. I never go without it. That is the most important thing I have. Call the patient. I call every patient the night before surgery, every patient, and I talk to them. And it's amazing how impressed and how that leaves a mark with them. When I was sending everybody home the same day and start, I would call them that same day. I've stopped doing that because almost all my patients go home the same day. But somebody does call them, and somebody calls them the day after surgery. So I tell them when they go home, here are the numbers to call if you have any issues, right down here. If you don't call us, we will call you tomorrow. And just the fact that they know somebody's going to call them tomorrow, they will avoid calling anybody the night of surgery. So in conclusion, what it is to improve and do your best, engage and educate your patients. Actively cooperate in their care. Be involved in everything that's done and everyone who touches them. Optimize them preoperatively. It'll minimize your complications and it'll improve your outcomes, along with risk modification and mitigation. The biggest improvements in my career that my patients have appreciated is when I allowed everybody to be weight-bearing as tolerated, when I incorporated a multimodal pain management protocol with preemptive medication before we put a knife to them, tranexamic acid, aspirin for DVT prophylaxis, preoperative optimization, education, my first nurse of 30 years, my second nurse now of 5 years, and my only 2 PAs, one of 15 and one of 17 years, and my telephone. Thank you.